Hey everyone, this is Rich Slama, and in today's 5-minute lecture series, we're going to be discussing aortic dissection. So, this is one of the very scary diagnoses that we deal with in the emergency department, and it's so scary because it can present pretty atypically, and really the only 100% way to diagnose this is a highly invasive CT scan. So, if we look at the physiology of how this works, you have here the inner layer, which is the intima, the media, and the adventitia, right? And so what happens is that blood tears through, at the very least, the intima, possibly the media, and dissects down through the layers of the aorta right here, of the artery, okay? And what's even worse about this is that it can go up, it can go down, it can really go anywhere. And the two patient populations that you worry about this, so you worry about the young people with connective tissue disorders. Your first would be Marfan's or Ehlers-Danlos, the people with stretchy skin and with the long fingers and the tall habitus. And then you would think about the older population, over the age of 50, with all of the typical risk factors: hypertension, diabetes, particularly smoking. And when we're classifying these, you kind of just have to think of the anatomy. There's the Stanford, and then there's the DeBakey type classification symptom. So the dividing point between aortic dissection is the ascending and the descending aorta. And what divides those two structures is the ligamentum arteriosum. And the ligamentum arteriosum, as you remember, is an embryologic remnant. So above the ligamentum arteriosum is the ascending aorta. So anything above the ligamentum arteriosum in the ascending aorta is a Stanford A, or DeBakey 1 and 2. And then anything below, as in B, below the ligamentum arteriosum is a Stanford type B or DeBakey type 3. Typically we stick with the Stanford classification in the emergency department. So what you really have to know about those, and here's just a repeat of what I just said, is that patients with a type A get treated surgically usually, and then type Bs usually get treated medically. So how do you diagnose these things? So I'll tell you that the most sensitive tests for this are a chest CT with IV contrast and potentially a CT angiography, which is a selective multiple phase contrast study of the chest. Now there are other tests that can suggest this diagnosis is going on, first of which would be your chest x-ray. You can also do a transesophageal echo, although those are not so common in the emergency department. Those can also be diagnostic. The x-ray findings that you would look for: a wide mediastinum, flattening of the aortic knob, and type of pleural effusion. And really, once you diagnose this, oddly, a lot of these patients are going to be hypertensive and tachycardic. So your goal is you want to decrease the shearing force on that dissection plane. And so what you do to control that is you want to get their systolic blood pressure to 110 to 130 and their heart rate of between 60 and 80. And the way that you do that, you give them a beta blocker. There are multiple ones. I'm not going to go into it. But you want to do a beta blocker first. That is the most important thing because it does both heart rate and it takes care of the blood pressure. And then if that's not working, then you can go ahead and add a secondary vasodilator, which can be nitroprusside or any of the other ones that are not beta blockers. And then all these patients are going to get ICU admission with the ascendings going to the OR, with the dissections being treated medically. So one last final point. This is just for style points mainly. Anybody with chest pain and symptoms, outside of the chest need to be evaluated for other catastrophes. So interestingly, patients with aortic dissections can have strokes, and the reason being is is that once you dissect the ascending aorta, that dissection can extend up into the carotid arteries, which can occlude and cause stroke-like symptoms. So just be aware that that's one possibility for these patients, because the dissection can travel upward. The second thing that can happen with these patients is that a patient can have an ST elevation MI because the dissection extended into the coronary arteries or artery. And so just be aware that these are mimickers. They have happened to numerous people before, and that you always have to take a careful history as to exactly what happened with these patients, as well as a physical exam. All right, and so that is all I have on aortic dissection. I hope you enjoyed it, and we will see you next time.